Good afternoon. This hearing will come to order. I want to welcome everyone to today's hearing titled Waiting for Care, Examining Patient Wait Times at VA. I would also like to ask unanimous consent that several of our colleagues be allowed to join us here on the dais today to hear about this issue that has directly impacted many of their constituents. Hearing no objections, so ordered. We should always be working to ensure veterans have timely access to quality care. However, today's hearing is necessary because evidence reviewed by the subcommittee, the Government Accountability Office, and VA's own Inspector General shows little improvement in that area. GAO recently completed its study that was appropriately titled Appointment Scheduling Oversight and Wait Time Measures Need Improvement. Despite claims of improvement under higher standards, we will hear today that a lack of reliable information when VA is measuring patient wait times. VA's own testimony supports that premise as it discusses what it sees as no reliable standard and an inability to accurately measure what constitutes a patient wait time. While the topic of patient wait times may sound like a very narrow issue, the problems in accurately monitoring and improving wait times for veterans at VA facilities is spread throughout the whole Department of Veterans Affairs. Schedulers at the facilities themselves have to use a cumbersome system that creates a significant chance of error. The problem runs all the way up to the Veterans Health Administration, which has an unclear policy on patient scheduling practices and still seems to struggle to best define its policy on patient scheduling. I understand that defining these policies is not easy, and that perfecting a process for appointment scheduling is a significant challenge, but VA has been well behind in this area for a long time. However, none of this excuses VA from its obligation to veterans. While I understand a system may not always be perfect, it does not mean that VA shouldn't make every effort to ensure veterans receive necessary care. Backlogs are a fairly common theme at the department, but that is no reason for VA to game the numbers to simply show better performance instead of providing medical appointments, sometimes for life-threatening conditions. Sadly, evidence obtained by this subcommittee clearly shows that in many cases, VA did not do the right thing. Instead, that evidence has shown that many VA facilities, when faced with a backlog of thousands of outstanding unresolved consultations, decided to administratively close out these requests. Some reasons given included that the request was years old, too much time had elapsed, or the veteran had died. This subcommittee asked VA for updates on these consultation backlogs beginning in October 2012. Despite multiple follow-up requests to VA, no information was ever provided, and it was only when this hearing was scheduled that the department offered a briefing on this subject. I would note that the subcommittee asked for information, not a briefing. Regardless, we should not be where we are now. This goes to reinforce that the Veterans Affairs Committee wants to work with the department on this and other issues, but that requires a willingness on VA's side to be forthcoming about its problems so that together we can identify ways to solve them. I now yield to the ranking member for her opening statement.
Thank you, Mr. Chairman, for holding this hearing this afternoon on the Veterans Health Administration's scheduling process and how that affects patient wait times for veterans. Improving access to health care is a continuous effort by VHA, and it is not surprising that we are here today. Excessive wait times and the failures of scheduling processes have been long-standing problems with the Veterans Health Administration. The Government Accountability Office has been reporting on this issue for over a decade. In 2001, the GAO reported that 2/3 of the specialty care had wait times longer than 30 days. In 2007, the VA Office of Inspector General reported that VHA facilities did not always follow VHA's scheduling policies and process. In 2012, the VA OIG reported that VHA was not providing all new veterans with timely access to full mental health evaluations. In that same year, the GAO again examined the issue and found that, among other things, there was inconsistent implementation of VHA's scheduling policy that could result in increased wait times or delays in scheduling timely medical appointments. In my Arizona district, in the city of Casa Grande, one of my caseworkers recently met with an Iraq veteran who made the brave decision to seek VA mental health care after 2 years of being back in the United States from Iraq. The VA required a physical exam before this veteran in my district could schedule an appointment with a mental health care provider. Unfortunately, they weren't able to schedule him for an initial physical for 6 months. That's 6 months of waiting before he could have even an initial consultation with a mental health care provider. And this was after 2 years of not seeing a doctor at all. These situations were able to be resolved by our veterans caseworker in the district, but the point is, veterans should not have yet another hoop to jump through. Access to health care should be easy to schedule. I also understand that VHA is operating with a reportedly outdated system that is cumbersome and slow. GAO reported numerous workarounds that some facilities are using, which may adversely affect timely health care delivery to veterans. Delayed care is denied care. This is all too evident with the rash of recent consult backlogs experienced at some of the VHA medical centers. It has been reported that thousands of consults in 2011 and 2012 were backlogged at various facilities, which may have resulted in adverse events due to the delay in diagnosis and treatment. This, of course, is unacceptable. Veterans deserve timely, accessible health care. They have earned it. What I would like to hear about today is a sound plan that will assist VHA in transforming into a 21st century organization and will eliminate as much as possible the needless waits, unclear policies and procedures, and frustrating technology that only serves to slow down the process. And I yield back. Thank you, Mr. Chairman.
Thank you. I ask that all members waive their opening remarks as per this committee's custom. However, I understand that Congressman McCarthy is going to have to depart early, and he was a main requester of GAO's work on this issue. I will yield 5 minutes to him for remarks. Congressman McCarthy.
Well, thank you, Chairman Kaufman, for holding this oversight hearing on the Department of Veterans Affairs, specifically the Veterans Health Administration, regarding the scheduling of a timely medical appointments, and for allowing me to make some remarks. You know, Chairman Miller and I led, along with 28 other members, in requesting the GAO to conduct this audit on the VHA and the scheduling of medical appointments, because I was receiving numerous complaints from veterans in my district who are waiting months for crucial medical appointments at either the local VA clinic in Bakersfield or the VA Medical Center in Los Angeles. One of the most common and disconcerting complaints from my veterans is that the VA Healthcare Administration lacks a sense of urgency when scheduling their medical appointments. This poor customer service means veterans are forced to wait months for the care when needed. One horror story a veteran shared with me was his experience replacing a set of broken dentures. The VA scheduled the veteran for 5 different appointments and took 6 months before finally replacing the dentures. As a result, this veteran had to eat 3 meals a day and half a year just in pain. In addition, veterans stressed to me that the VA is unsympathetic and unhelpful when it comes to ensuring that they are taken care of from the start to finish. When veterans in my district are scheduled for an appointment at the VA Medical Center in Los Angeles, they must travel over 2 hours over mountain roads and through LA traffic. Smarter scheduling equals fewer trips to LA for my constituents and more efficient use of VA staff time. One veteran who came to me was having difficulty obtaining an appointment with the VA to receive a knee replacement. After removing the first faulty knee replacement, the VA then required the veteran to make 6 different trips. This is a 200-mile round trip from Bakersfield to LA, in order to sign releases and take tests before the VA would proceed with his surgery. It was not until our office contacted the Greater Los Angeles healthcare system that he was finally scheduled for his knee replacement, bringing the situation to a close after 8 grueling months. Finally, when the VA does schedule a veteran for an appointment, all too often I hear they fail to notify the veteran in adequate time for he or she to make an appropriate travel arrangements. One local veteran who was waiting for an eye surgery appointment was notified that he had been scheduled for his surgery in Los Angeles less than 24 hours before he needed to arrive. He was forced to cancel his appointment as he was unable to find transportation to the surgery on such short notice. Even though our office attempted to assist him with the VA-approved surgery, the veteran grew so tired of waiting for the VA to reschedule, he had the surgery conducted with a non-VA ophthalmologist having to pay for the procedure himself. These are just several stories that I've heard from my veterans and are far from isolated incidents in my district as evidenced by the GAO report, but are indicated of a larger systematic problem within the VA medical centers. The experience these veterans have faced are inexcusable and should not have to happen to our nation's finest. I think all of us here today can agree that this is a problem that needs to be immediately fixed, especially since we are facing a reverse surge due to the Department of Defense and reducing the troop levels and drawing down in Afghanistan. So I thank you, Chairman Kaufman, for your work on this, Chairman Millers, and the entire committee, because this is an issue that is not partisan. This is an issue about the respect that we give to those that risk the entire lives for all of us to have our freedom, and how we treat individuals of this nature is unacceptable in what has gone on. So I thank this committee for their work on the GAO study, and I thank them and will pledge to do everything in our power to make sure we correct this as well. And I yield back.
Thank you, Congressman McCarthy. With that, I invite the first panel to the witness table. On this panel, we will hear from Mr. William Schoenhard, Deputy Undersecretary for Health for Operations and Management at the Veterans Health Administration. Mr. Schoenhard is accompanied by Dr. Thomas Lynch, Assistant Deputy Undersecretary for Health Clinical Operations and Management. Mr. Philip Lukavsky, if I'm saying that right, Assistant Deputy Undersecretary for Health and Administrative Operations, and Dr. Michael Davies, National Director for Systems Redesign. We will also hear from Ms. Deborah Draper, Director of Health Care at the Government Accountability Office, and Mr. Roscoe Butler, National Field Service Representative for the Veterans Affairs and Rehabilitation Commission at the American Legion. All of your complete written statements will be made part of the hearing record. Mr. Schoenhard, you are now recognized for 5 minutes.
Thank you. Chairman Kaufman, Ranking Member Kirkpatrick, members of the committee, thank you for the opportunity to come today to speak regarding a subject that is important to the care of our nation's veterans and to their satisfaction. For veterans who have sacrificed all, as Congressman McCarthy referenced on our behalf. Let me first just express regret for the incidents of breakdown in care that was described by the ranking member and by Congressman McCarthy. Any veteran who goes without timely care, where their care and satisfaction is impacted, is one veteran too many in terms of our commitment to serve those who have served us. I'm accompanied today, as you said, Mr. Chairman, by 2 assistant deputies, Mr. Matowski and Dr. Lynch, for administrative and clinical services respectively, and Dr. Michael Davies, the National Director of Systems Redesign. As I mentioned earlier, and as was mentioned by members of the committee and Congressman McCarthy, Timely access to care is important to both clinical care as well as the satisfaction of our veterans. We're grateful for the oversight of this subcommittee. We're also grateful for the report of the GAO and the IG. We have been on a long journey to see what steps can be taken to ensure we have reliable and valid measures to measure wait time and the methods and implementation practices to ensure consistent implementation of those across our system. We are also informed by our own study of millions of veterans' appointments, as well as patient satisfaction surveys that suggest that there is need for improvement, as we acknowledged in our acceptance of the 4 recommendations of the GAO, as we determine how to go forward and better improving our care to increase patients' experience with our system. I think it's important to say there are 2 parts to this effort going forward. First is to have reliable and valid measures to measure wait time. And as is indicated in our written testimony, we have changed the measure for new patients in order for that to be more valid and reliable. And we have undertaken a change with regard to the agreed upon date that the provider and the patient will establish together as a patient visit is completed. That is informed, as I mentioned before, by the various reviews in our own study. It's important that we have measures that we know will better serve our veterans and reliably be implemented across the system. Having said that, as important as that is for a foundation, execution is the most important part going forward. And I would offer that in our experience of the past 20 years and what we've learned from the recent studies is that we need to do a better job of integrating our administrative and clinical implementation of this effort going forward. That's why I'm accompanied today by the 2 assistant deputies. We need to ensure, as we have for the measure for new wait times, that we have effectively piloted these measures with providers in the real world to determine that they work and that they better serve veterans. We need to ensure that we have going forward more robust and complete training of our staff who actually implement these practices and schedule our patients. We need to ensure that we have staffing guidelines for schedulers to ensure we have sufficient supply and training of those who do this important work. And I have sat with those who actually go through the scheduling process, and as mentioned by the ranking member, we need to have better tools for their use, an automated scheduling system to go forward. Finally, we must have feedback loops to ensure that we have continuous improvement and reality check on what we do going forward. I pledge to you and to the subcommittee that this is an effort that will be implemented in an unprecedented way. As we go forward, this requires joint administrative and clinical engagement, and we will ensure as part of that process accountability and oversight to ensure at all levels of our organization that this is implemented in a way that is veteran-centric and important to their care. We thank you for the opportunity to be here, and my colleagues and I would be happy to answer questions.
Ms. Draper, you are now recognized for 5 minutes.
Chairman Kaufman, Ranking Member Kirkpatrick, and members of the subcommittee, good afternoon. I am pleased to be here today to discuss VA's reported outpatient medical appointment wait times. The bottom line is that it is unclear how long veterans are waiting to receive care in VA's medical facilities because the reported data are unreliable. Access to timely medical appointments is critical to ensuring veterans obtain needed medical care. However, long wait times and a weak scheduling policy and process have been persistent problems for VA. For more than a decade, both we and the VA's Office of the Inspector General have reported on these problems. In my statement today, I will discuss key findings from a report we issued this past December that examined the reliability of VA's reported medical appointment wait times, as well as the scheduling policy and process. We found that VA's reported wait times are unreliable because scheduling staff do not always correctly record the required appointment desired date. That's the date on which the veteran or provider wants the veteran to be seen. This is due in part to lack of clarity in the scheduling policy and related training documents on determining and recording desired date, a situation made worse by the large number of staff who can schedule medical appointments, which at the time of our review was estimated to be more than 50,000 people. During our site visits to 4 medical centers, we found more than half of the schedulers that we observed did not record the desired date correctly, which may have resulted in a reported wait time shorter than what the veteran actually experienced. Some staff also told us they changed medical appointment desired dates so that the dates align or the wait times align with VA's related performance goals. We found additional problems in how the scheduling policy was implemented, which may have also resulted in increased wait times and delays in care. For example, an electronic wait list, which is required for tracking veterans needing medical appointments, was not always used, putting veterans at risk of not receiving timely care. We also found follow-up appointments being scheduled without ever talking to the veteran, who would then receive notification of their appointment through the mail. Additionally, the completion of required scheduler training was not always done, even though officials stressed the importance of training for ensuring adherence to the scheduling policy. We also found a number of other factors that negatively impacted the scheduling process. These included the VISTA system used for scheduling, which officials described as antiquated, cumbersome, and error-prone, shortages and turnover of scheduling staff, and high telephone call volumes without sufficient staff dedicated to answering these calls. VA is implementing or piloting a number of initiatives in an effort to improve veterans' access to medical care. For example, one such initiative is Project Arch, which aims to provide health care through contracts with community providers to reduce travel and wait times for veterans who are unable to receive certain types of care from VA in a timely manner. While information is being collected on wait times for Project Arch, these wait times may not actually reflect how long veterans are waiting to receive care, because the wait times are measured from the time authorization is received from VA rather than from the time the veteran first requests the appointment. In our December report, we recommend that VA take actions to improve the reliability of medical appointment wait time measures, ensure the consistent implementation of a scheduling policy, allocate scheduling resources based on needs, improve telephone access, including the implementation of identified best practices. VA concur with our recommendations and identified actions planned or underway to address them. To conclude, while VA officials have expressed an ongoing commitment to providing veterans with timely access to medical appointments and have reported continued improvements in achieving this goal, unreliable wait time measurement has resulted in a discrepancy between the positive wait time performance VA has reported and veterans' actual experiences. More clarity in and consistent adherence to the scheduling policy, improved oversight of the process, allocation of staff resources to better match scheduling demands, and resolution of problems with telephone access are needed to reduce medical appointment wait times. VA's ability to ensure and accurately monitor access to timely medical appointments is critical to providing quality health care for veterans who may have medical conditions that worsen if care is delayed. Mr. Chairman, this concludes my opening remarks. I'm happy to answer any questions.
Thank you for your testimony. Mr. Butler, you are now recognized for 5 minutes.
Good afternoon, Chairman Kaufman, Ranking Member Kirkpatrick, and members of the committee. On behalf of our National Commander, James Cox, and the 2.4 million members of the American Legion, I want to thank you for looking into the problems American veterans are having accessing their health care. Whether it's frustration with repeatedly being put on hold, waiting 3/4 of a year for a basic primary care appointment, or being forced repeatedly to adjust to new primary care providers, the needs of veterans are not being met. I want to ask you really to take the time to read through Appendix A of our testimony. These are real veteran stories, raw and unfiltered, that provide a realistic picture of what's happening to the people of the system. Time and time again, we see veterans who love the care they receive. when they can get it. The frustration of the ability to access what is otherwise excellent care has been a factor we've seen in our system worth-saving visits for the 10 years we have been performing these visits. It's important to remember these veteran stories because that's the real impact we're talking about. This is not about meeting targeted numbers or looking at where results fall on a chart. This is about what happens to real people who have sacrificed for their country with their military service and are now frustrated by an otherwise excellent healthcare system. Some of the wait time could be improved if VA did a better job delivering on extended hours for health services, especially mental health. We know VA is trying to address this, and they released a VHA directive on January 9th of this year. Unfortunately, from our experience with visits in the field, this directive will not go far enough to meet the needs of veterans. The new policy states that any facility that treats more than 10,000 veterans a year has to have an extended session during the week and one on the weekend. But the required sessions are only 2 hours. The American Legion is concerned that 4 hours a week simply won't be enough to meet the demands of veterans at these facilities. We believe VA needs to continue to refine the policy to make sure they really are meeting the needs of the veterans. To address one of the other major problems with wait times, VA must address the problems with their scheduling system. After nearly a decade of indecision between off-the-shelf software and in-house designs, the entire project was dropped in late 2009. Now, 3.5 years later, there's still no fix in place. There is an open call for submission from the Federal Register to end in July of this year. But our veterans deserve a clearer and better plan in place. We hope VA can provide details on how they will be able to implement a 21st century scheduling software system. The most frustrating part of the process, something has been since Commander Connolly started the system worth-saving visits in 2003, is that when veterans can access the VA system, they really have good things to say about the care they receive. The American Legion believe VA needs to do a better job getting veterans to this care and on a more timely basis. Read through the reports. There's no reason a veteran should face 9-month delays just to see a primary care provider. I thank you and the committee again for looking into this, and I would be happy to answer any questions you might have.
Thank you, Mr. Butler. Mr. Schoenhardt, GAO reports significant failures in scheduling appointments that span at least 7 years. In addition to this, this subcommittee has identified a backlog of hundreds of thousands of appointments based on VA's own documentation. How is VA addressing this tremendous appointment backlog?
Sir, we are addressing this in a variety of different ways. And in terms of new patients, we're creating a new measure to go to create date to ensure, particularly for those who are needing access to our system for the first time, that within 14 days we would schedule their appointment from the time the appointment is scheduled. Not when the patient desires to be scheduled, but the clock starts the time the appointment is being made, because we believe that is a more reliable and valid measure of making sure veterans are able to access our system. So that's an important first part. Also, we are in the process of undertaking a complete review of consultation requests. We have developed new information system tools to be able to have visibility of this at all levels, and we are addressing that in a system-wide review and putting in place work groups that will ensure that we have better visibility than we've had in the past of these consult delays, and that we're acting on them in a way that provides proper oversight and audit of that going forward.
My concern is that VA has or will clear this backlog by simply administratively closing appointments, as they did with 13,000 appointments in Dallas and approximately 40,000 appointments in Los Angeles. Why isn't VA using community providers more efficiently?
Sir, you touch on a very important aspect of our care, and that's being able to use community providers in order to better serve our veterans if we are unable to serve them. I wonder if I could ask Mr. Matowski, please, to expand further on the non-VA care efforts we're making to ensure this is done.
Please.
Thank you. Mr. Chairman, we have begun in fiscal year 2012 rolling out a care coordination module for non-VA care. It allows us to actually be more systematic in how we review referrals to the non-VA care providers, so the care in the community. Rather than ad hoc, it allows us to collect all of the referrals for non-VA care, ensure that folks are scheduled timely, and that they can be seen in a timely basis. We do that by actually collecting the referral request, having a standard form of authorization for each referral, and then being able to monitor how that referral is worked in the community. What we don't want to do is have someone who might be experiencing a wait time in the VA experience the same wait time in the community. This allows us to monitor them both. That process will be fully deployed across all of our medical centers by the end of fiscal 13. It's an important change. It may not sound like it, but allows us to more strategically and more systematically use our non-VA partners in delivery of care. We have also begun a few larger contracting initiatives, which we have briefed this committee subcommittee, that will give us standardized access to care based on performance.
I mean, I'm still not clear on how we're talking about hundreds of thousands of backlog appointments. I mean, what you're going to do today to get that, to take care of this?
We are not going to administratively close any appointment for care for a veteran. I think you reference a couple instances where there may have been referrals that were actually completed but simply not closed out, sir.
You mean the 13,000 in Dallas and 40,000 in Los Angeles, the couple that few that I referred to?
No, sorry, sir. I meant the few examples you gave. But no, we will not close out any appointment administratively where a veteran is waiting for care at all.
Mr. Schoenhardt, according to VA documentation, in many instances, veterans were harmed or died due to delays in getting treatment. How many adverse events nationwide is VA aware of due to these delays?
Sir, we have undertaken review of our facilities, and we are in the process of completing that review. We have instances of institutional disclosure that has occurred throughout our system. I asked Dr. Lynch to expand on this, but if I could turn to you and if you could give the report.
Thank you, Mr. Schoenhardt. If I could begin by backtracking for just a second and discussing the process by which consults have been reviewed across VA. The VA consult system is not an ideal system, and unfortunately it contains not only clinical consults but also the consult process that has been used for administrative purposes. In certain cases, consults have been used to schedule tests rather than specific patient visits. In some cases, consults have been used to schedule advanced appointments 3 or 4 years in the future. These are called queuing consults. The process of reviewing consults has been very careful. We have looked at the reasons for all of the what we term unlinked consults, carefully evaluated whether they are of clinical significance before making a decision whether or not they can be administratively closed. Any of the consults that have been closed to date have been evaluated, and there has been assurance that there has been no risk to patient care or to patient life, sir.
Ranking Member Kirkpatrick.
Ms. Draper, how confident are you that the Veterans Health Administration will be able to effectively make improvements in the reliability of their reported medical appointment wait times, scheduling oversight, and initiatives to improve access to timely medical appointments?
There's a lot of work to be done, and I think as we've reported over for more than a decade, there have been a lot of initiatives started, and the problems still persist. So I think they have undertaken a number of initiatives to improve the measurement of wait times. And let me just say, the measurement of wait times is really important for a number of different reasons, one of which is workload management. So you don't really know how much capacity, excess capacity you have, whether you have any. So it really is an indication of how fast or what other resources you might need to get veterans in to be seen timely. So it remains to be seen. It's a hard question to answer based on previous experience. As I said in my testimony, we have reported on these problems for more than a decade, and there is a lot of work to be done. And I will say it's not just the wait time measurement, but it's having clearer policies, better allocation of staff. There needs to be a lot of what we heard around a lot of problems around telephone access, so there needs to be better management of the telephone system. And the 4 sites that we visited, we had evidence of long on-hold times and also of high call abandonment rates. So it's a very complex issue, and it's not just one thing that's going to fix this. There's a lot of things that need to be addressed.
In your opinion, what do you believe is the number one challenge VHA faces as they move forward to making improvements and moving the scheduling process into the 21st century?
Well, it's very important to have a clear policy. Right now, the policy that, as when we were reviewing it, there's a lot of ambiguity in the policy. So it left a lot of discretion. So you saw considerable variation from one facility to another. So one thing is clear policy, clear implementation of that policy. There needs to be oversight. One of the things that VA has done is that beginning in 2007, the individual medical centers were to do a self-assessment and report their compliance with the scheduling policy. And I think that what we saw was more than 80% or close to 80% of the facilities that completed that self-assessment said that they were in full compliance with the scheduling policy. And we know from 2 of the facilities that we visited that said that they were in full compliance, that was not the case.
Again, Ms. Draper, the GAO reported that a scheduler at one of the primary care clinics specifically stated that she changes the recorded desired date to the patient's agreed upon date in order to show shorter wait times for the clinic. Clearly that should not happen. I think we all agree with that. While visiting the facilities and talking to staff, did you get a sense that the employees were unduly influenced to make sure that shorter wait times for the clinic were reflected, even if it weren't true?
I can tell you we heard this across several facilities. So as you mentioned, in one primary care clinic, we did hear that the scheduler changed the dates to show that there was no long wait times. In another specialty care clinic, we heard that providers were changing dates to make sure that their data showed that they were within the 14-day timelines of VA. We also went to one specialty clinic, and it showed a 0-day wait time, so they were changing the desired date to the appointment date. So what happened is, in reality, there was a 6 to 8 week backlog at least. So someone in another part of the facility could look at the scheduling system, and it looked like there was no wait time, so they would send someone over, when in reality there was a long backlog of appointments. So while we weren't specifically told that they were directed by management, I think the current situation provides ample opportunity to change dates, whether intentional or not, to really reflect the results that you want to achieve. And I just want to say too, I mean, these measures are used in a lot of different ways. They are included in the network and medical director performance plans. They're also included with VA's budget submissions, and they're also included in the VA's annual performance and accountability report. So there's a lot of incentive around these measures.
Thank you for your testimony, and I'll yield back the balance of my time.
Thank you, Ranking Member Kirkpatrick. Ms. Walorski.
Thank you, Mr. Chairman, and thank you to the panel. In the state of Indiana, in my district, have 52,000 veterans just in my district alone. And our little state of 6.5 million people that sits in the middle of the country plays a significant role in military operations around the country. We have the 4th largest National Guard. I find it shocking to sit and to hear these stories time and time again. And Mr. Schoenhardt, in your testimony today, you talked about reliable, valid measures, and you talked about having these feedback loops. And I'm shocked about it. Before I ask you this question, I'm shocked about it because when the military is in need and our country is in need, Hoosiers respond in a rapid form. Our Hoosiers are often the first line of defense and the first folks to go. So when our nation calls them, they go. When they need help from our nation, to have the kind of stories that we hear is it's very sad and it's shocking to me. So what feedback loops have you put in place that are going to try to correct these problems, given the past of how long it's taken to actually unveil these issues in the form of a hearing?
Congresswoman, I would say that the first feedback loop we've used is to pilot test the new measure for new patients, moving it from desired date to create date. This will be a hard time stamp at the time a veteran is making an appointment until the appointment is actually made. Part of the problem we've had in the past is that as the scheduler has asked a new patient when they would like their desired date, sometimes the veteran may ask to put it out somewhere in the future. They may be going on a trip or somewhere, and they may want to not feel an urgent need to get in. And so we've been measuring the wait time around that desired date. Moving it to the create date will put emphasis on the day the appointment's being made. Is that appointment made within 14 days or not? And part of what we've experienced in the past is that veterans like myself often are appreciative of the care VHA renders, and they will ask, well, when do you have a spot available? They're trying to be accommodating unless they have an urgent need. And you get into this circular conversation. Well, it's not when we're available, it's when you want to be seen. All of that will go away with the new create date, where we will work to get them in the system, because I couldn't agree more from my visits with veterans and our own review. The perception of care is higher among those who use VHA than those who have not. And so we want to get them in our system. And we owe it to Hoosier veterans, we owe it to veterans throughout this nation for all that they've sacrificed, particularly in these wars, to get them in as soon as we can.
I appreciate it. And Ms. Draper, I appreciate the GAO summary as well and find it revealing. Is it your belief that the recommendations that we've talked about today and the recommendations in the report will suffice in turning some of this stuff around? And my counter question to that is there a competency level at the staffing level that needs to be addressed, or can this completely be streamlined through programming?
Well, it's interesting you asked about this. I assume you're talking about scheduled staffing. These are what we've heard is these are high stress, demanding jobs, and they're really entry level pay grades. So we saw a lot of high amount of turnover in these positions, and what we heard in the facilities that we visited, that high performers tend to get promoted quickly out of the scheduling role. So you have a lot of turnover, and I think it's one of the issues is that this may not be a resource issue, it may be an allocation issue, and because VA really has not determined what its scheduling staffing needs are. So I think that, just to give you a sense of what happens when you don't have sufficient scheduling staff is that often providers are picking up for where schedulers are not completing their responsibility. So that really takes away time from their direct patient care. So there's just a lot of issues that come up, and it's not as simple and straightforward as a lot of things happen when you don't have sufficiency of staffs.
Thank you. I yield back my time, Mr. Chairman. Thank you.
Thank you, Mr. O'Rourke, Texas.
Thank you, Mr. Chairman. Ms. Draper, in some of your comments, you touched upon capacity, and in El Paso, I often hear from veterans that when they are seen by a doctor at the VA, it's excellent care, and they have no complaints, and really are just full of praise for the quality of care, the professionalism, the attentiveness. The challenge is getting in a lot of times and having an appointment set and then canceled and reset, and it's particularly acute for mental health care. And we recently found that there are nearly 20 unfilled positions for mental health professionals in the El Paso VA. When you look at the fact that we have 80,000 veterans in our service area, and we don't have a full-service VA hospital, we have this shortfall in our mental health professionals, and if you want to go to an acute care hospital, it's in Albuquerque, a 10-hour drive round trip. Did you find that capacity in terms of mental and physical health care professionals was part of the problem in getting the wait times that were desired?
We did not look at mental health care because the VA IG really addressed that issue, but we looked at other specialties in primary care. And what we heard was that often that is part of the backlog reason is there are not enough providers, and the providers that are there are really, what officials at the medical centers told us, that they're often really stretched. And going back to consults, for example, consults are supposed to be triaged within 7 days of receipt. So that falls typically on a clinician to review those consults. And some specialty clinics, they can get 40, 50, 60 consults a day. So someone's got to take care of those. So if you got a short-staffed clinic to begin with, and then trying to add on these other ancillary duties, it really does become a scheduling nightmare.
Mr. Schoenhardt, how can we work with you? We met with the VHA director in El Paso, Mr. Mendoza. Again, they're doing a great job, but I think they're working with limited resources, and they need more help. And they're challenged by not just having these unfilled positions in their manning table, but we also have a great active duty full-service hospital at William Beaumont East, which I think at times poaches health professionals there. Are we not paying enough for, in this case, mental health professionals or primary care professionals? Are we having a hard time attracting and retaining talent at our clinics and VA hospitals?
Congressman, first I will follow up with the El Paso situation and look into that personally. We are in a major effort, as I'm sure the subcommittee is aware, of hiring additional mental health professionals. We are doing site visits to our facilities. It's important not only that we recruit, but that we retain mental health professionals. That's part of the vacancy, that's part of the turnover situation going forward. We need to create the best practice environment for our mental health providers of anywhere in the United States. We should lead in that effort in VHA. And it's important that we not only address new positions, but that we fill vacancies. As it relates to benefits and salaries, we have had historically some struggle in being competitive in the recruitment of psychiatrists. Steps have been taken to ensure that. Psychiatry is a shortage everywhere. Having come from the private sector, I can say particularly in rural areas, of course El Paso is not that case, it's very difficult to recruit psychiatrists. And so we use telemental health and other ways in which to provide care, which actually has been very well received by our veterans. But we need to ensure we have the wherewithal to effectively retain and recruit mental health providers, and we continue to evaluate that with a major effort in human resources.
Thank you, and thanks for your offer to follow up on those vacancies in El Paso. Mr. Chairman, I yield back.
Ms. Waltz?
Thank you, Mr. Chairman, and thank you all for being here. Ms. Draper, thank you for your work. I've made it no secret in here. I'm a big fan of GAO and IG and the oversight. Mr. Schoenhardt, thank you. I've also made it clear I'm the VA staunchest supporter and the harshest critic. And if I'm not mistaken, you yourself are a veteran. And
yes, sir.
As are what percentage of your people who work at the VA?
Sir, I would need to check, but at least 30%.
Yeah. Well, I was just going to say, I wish the distinguished whip would have waited for answers today. And I do bristle a bit at the idea of indifference. I'd like to know a name of which person in the VA was indifferent, because I think to paint with a broad brush the number of people at VA that are out there doing a good job, I'm not going to defend you when you fall down, and I simply think we can do better. But I think painting with a broad brush, I had some statistics here. This is a 3-year-old study. These are average wait times in the civilian sector for a doctor's appointment. 63 days in Boston, 59 days in Los Angeles, good here, 27 days in Detroit, 47 in Minneapolis. I think many times what we forget here is comparing apples to apples across there, and I know, Ms. Draper, that was not your charge to the private sector, but we pay a lot of money into the private sector in the form of Medicare and things like that. So when we're talking best practice and we're adding things, it's certainly not for the desire to care. The thing that frustrates me is that I see an unevenness in application. And Ms. Draper, are all VA facilities created equal in your mind on how they do this?
Are you referring to how they implement the
Yeah.
policy? No.
Yes.
We found considerable variance from facility to facility.
Are there some that are doing this outstanding and it could be made to say that they're doing it world class?
I would say in the 4 facilities we visited, we found issues in all 4.
Okay.
And they ranged, from very
I see it even very small geographic areas between St. Cloud and Minneapolis. I see a difference in wait times on there and how that works. So I think it's trying to both integrate a unified putting the system in and allowing for geographic variance. But I think one of the most frustrating things for me is the uneven care that veterans receive at different facilities. Mr. Shorner, can you talk about that on how you address that or how you deal with the competing desire of local control versus a centralized system that provides that uniform quality care?
Well, sir, let me begin with a statement that veterans should expect the same standard of timeliness, access, quality in their care, whether it's Manila or Maine. It should be throughout our system. We are a national system.
And ironically enough, I was just in Manila. It might be better there than anywhere I've been. Just as a side note to you, but please go on.
We will learn from them. But we owe it to our veterans to ensure more consistent delivery of timely, quality care. That's an expectation we have here in the central office in Washington of our VISNs. We rely on our VISNs to ensure that they are providing consistent care within their regional footprint. And it's our responsibility to ensure oversight and monitoring of the VISNs doing their work with the facilities. We have that
So
responsibility.
these implementations or these corrections that were given to us, will these help improve system-wide, or will these help improve these 4 facilities that were looked at?
It will help the 4, and it will help the others who also are in need of improvement. I'd like to ask Mr. Matowski to expand on the plan going forward, because I think it is a more robust effort than we've ever had in this case.
Thank you, Mr. Schoenhardt. And I would indicate that I would agree with Ms. Draper's analysis. For a program, we require good, clear, measurable policy. So as we work on the new set of dates, it has to be clearly defined, and we have to be able to relay that to everybody in the field who we're expecting to hold accountable to this new set of standards. Our first step was adjusting some of our policies using a date that's easy to understand. After we do that, we have to test this policy rather than roll it out system-wide via a memo. It's our responsibility as a program to test it in its application. Make sure that the training we provided staff on the front line, training we provided the providers was adequate, that it answered the mail. Any changes we made to systems were easy to use and resulted in a measure that was reliable in each of the clinics that we applied this change. After we roll it out, the next thing that we require, you mentioned the tension between local care, all care is local, and oversight. It's our job to pay attention as well, to look at the performance, to establish measures that allow us to track the averages, but also allow us to track some of the stories that Mr. Butler relayed, anywhere where there might be a wait that's too long. It's our job to actually evolve our management, our oversight, and have that constant feedback that is always looking at how to improve performance, and that's what we are doing differently this time.
Well, I appreciate that, and with the outrage that we express, I would just always ask us is how long you've been waiting for us to do a budget and sequestration. It's fair is fair. Emerson might have been right, how much of life is lost in waiting, but thanks, I yield back.
Thank you, Mr. Walz.
Mr. Chairman, may I have just a moment?
Oh, yes, go ahead.
Thank you very much for having this hearing. I want to thank the panel and the guests. The Democrats on the committee are leaving to go meet with the president, so I didn't want you to think we're just walking out of the hearing, but we need to meet with him at 2 o'clock, so thank you.
Thank you. Dr. Lynch, I believe you stated in your testimony that you were not aware of any deaths of any veterans due to delayed care. Is that correct?
We were talking about consults to begin with, and let me, if I may, explain a little bit about how the consult process works. There are two sides to a consult. There is the consult itself, the ask, and there is the response or the physician reply. There is a third component to that which links the two. When the team from VHA undertook to assess consults, they did it in a standardized fashion. We looked first of all at all of the consults over a 5-year period.
May I rephrase the question? Are you aware of any deaths of any veterans due to delayed care?
With respect to the consult look back, no, sir. With respect to what had occurred in Columbia and Augusta, we are aware that there were some clinical disclosures made and that there were veterans who had died with a disease process that could potentially have been related to consult delay.
Well, yeah, I think by the internal documents here, and actually you're fairly specific, that it is in May that it in fact, the delay in treatment did cause the death of a veteran in South Carolina. And another date on May, another internal document last year, May 15th, speaks to the Dorn facility, speaks to another death due to delay in care. So I think that clearly there are, by your own internal documents, there are issues concerning the quality of care related to timeliness and unfortunately the loss of life unnecessarily of veterans. And that's particularly alarming. Mr. Schoen, let me go over here. Schoenhardt, when did you become aware of this problem?
The problem being console backlog or back?
The very problem we're discussing here today. Oh. When did you become aware of it?
Well, I would say the overall issue of wait times, I would say, is a matter that I have been concerned about since arriving when I was appointed in 2009.
In 2009?
Yes, sir.
And now it's 2013, and we're having this discussion?
Yes, sir.
And why are we here today?
I think we're here today because of a number of factors, most of which deal with better execution going forward in the consistent training, testing, and implementation of our scheduling package with measures that are more reliable and more valid than we've had in the past. As I said in my opening statement, I think it begins with the measurement system itself. And I am convinced from what we have learned from the GAO, the IG, particularly the IG review of mental health, that was very helpful last year, that especially as it relates to new patients, moving back from desired date, which was the change made in 2009, back to create date will be more veteran-centric, more reliable, and get veterans into our system for care sooner than they have in the past.
Mr. Schoenhardt, has VA's medical inspector, Dr. John Pierce, come to any conclusions as a result of this large-scale failure to care for veterans?
I think that from Dr. Pierce's report, it showed clearly that we had the important need to do two things: address the delays in the facilities that he had visited in Columbia, South Carolina, and Augusta, Georgia. As important as it was for us to vigorously respond to that report from Dr. Pierce in the O&I of those two facilities, it was as important as that was to ensure we were providing system resources and vision resources to those two facilities, it was equally important that we do a system-wide review to see if this was an issue anywhere else. And that's the process that Dr. Lynch was describing. Because whenever we have a problem arise in a particular facility or two facilities, we have a responsibility to ensure veterans throughout VHA that we are undertaking a review to see if this is the case anywhere else.
And when can the committee see that report?
I would have to take that for the record, sir. I don't know, but I will certainly take that for the record.
When can the committee see that report?
Sir, if I could take that for the record, I will provide an answer as soon as we can.
You'll provide the report?
I would have to check and make sure that I can tell you the time within which the report would be rendered.
Is the report? Oh. Mr. Butler, you mentioned that the Legion's task force had identified a list of 14,000 veterans waiting months for appointments in Bay Pines. Can you cite other locations?
We visited our System Work Savings Task Force. Our System Work Savings Task Force has visited a number of VA facilities, and while I can't specifically identify at this time facilities that have excessive wait time, I'll take that information for the record, but I can tell you that on as recent as a visit on yesterday, we found that there are some facilities where, when we talk about the electronic wait lists, we're still finding facilities that are still using paper lists. So not all the appointments are being recorded electronically. Therefore, the wait time is not accurately being reported as it should be.
Thank you. Mr. Hulskamp?
Thank you, Mr. Chairman. I apologize for my tardiness in arriving. I'd like to ask Ms. Draper a question of her report and piecing through that. But one issue in particular particularly disturbing, which you note that staff at some clinics told us they changed medical appointment desired dates to show clinic wait times within performance goals. How widespread was that pattern of behavior, and can you describe that a little further for the committee?
Yeah, we actually found this in several places, so it was not a one-time occurrence. So, for example, in one primary clinic, a scheduler there told us that they changed the dates to make it look like they had short wait times. In a specialty care clinic in another facility, a scheduler there said providers changed the dates to ensure that it reflected wait times within the 14-day timelines of VA's performance goals. So, another example, I mean, we had quite a few examples, and another specialty clinic in another facility showed a zero wait time where they set the desired date to the appointment date, so it showed a zero wait time, and in actuality, when we went there, it was a 6 to 8 week backlog of appointments. So, I think this question came up earlier, and part of the issue is the way there's a lot of confusion among schedulers about what they're supposed to be doing. No one specifically told us that they were asked to change the date by leadership, but I think the situation as it currently exists, it provides ample opportunity for dates to be changed, whether intentional or not, to reflect the results that you want to achieve.
I appreciate it. And I apologize, Mr. Chairman, if the question has been asked before. I want to follow up a little bit more. Is this, in your understanding, is this illegal under
Well, it's against scheduling policy, so it's just, they're not in compliance with the policy of the process.
Okay, and I'll ask the VA, I mean, how do you handle these employees, and what have you done with this information?
Well, sir, gaming the system, if that's what's being suggested here, by changing dates in order to ensure that the results look better for performance reviews, is entirely unacceptable. Entirely unacceptable. And when we are visible, when that is visible to us, we will take appropriate action. And I will follow up with the GAO report to determine this more specifically.
Yes, and
what we need to be doing is ensuring we're taking care of veterans.
Well, assuming that what we've seen matches up with what you're saying, Sir, what is the penalty for an employee that is violating this policy? How would you handle that?
Well, sir, we would review the case in each individual case to determine what was the facts and the circumstances, and
Well, let's just establish that the facts indeed occurred as indicated. What is the penalty for I wouldn't even call it gaming the system. That's cheating. And what's the penalty?
the penalty would depend on the seriousness of the offense.
So if they changed it and moved it 6 weeks and did this repeatedly, what would be the penalty in those circumstances?
Sir, I would have to say it would depend on the individual circumstance, but it could lead up to termination.
Okay, well, I look forward to a report on that. And, Mr. Chairman, I might note, I'm going to reiterate a request I've had to the VA for, I think we're up to 6 or 7 months now in reference to budget data. I think we have 23 unanswered questions and in reference to data out of the VA. And I appreciate you coming forward to this committee and subcommittee and giving some information. But I've had, again, multiple unanswered questions, basic budget data in reference to travels and activities by your employees that your agency has refused to provide information. And it's very hard to build a level of trust that we need to move forward to help and achieve the goal of helping our veterans when you refuse to answer, again, basic budget questions. So I appreciate if you take that back to the folks in charge. And so it's been a number of months, so certainly we can figure out what responses we need to give to the congressman other than simply ignoring those. I yield back, Mr. Chairman.
Do that, sir.
Thank you. Mr. Schoenhardt, and I'd like to thank the entire panel, Mr. Butler, for your testimony, Ms. Draper, Mr. Schoenhardt, and your staff. I just want to say that you've been here since, in this position since 2009. You came in, obviously, the system was in chaos and not serving the veterans community. You've been there. You haven't made a difference. And I have no reason to think that under your leadership, unfortunately, that this job is going to get done. With that, committee is recessed.